Welcome to the Next in Health podcast. My name is Igor Belokrinitsky. I'm a principal with PwC Strategy End, where I help leading health organizations with their strategies and operating models. And at PwC, we are outcomes obsessed. And today we have a guest on the podcast who is also outcomes obsessed. And I'm very excited to welcome Stephen Pollak, our executive in residence, to the podcast. And we'll be talking about how to achieve great outcomes for complex patients. And we'll go deep into this topic with Steve because he has great experience in the space. And then we'll expand the conversation, talk about how to apply these lessons learned across large health ecosystems. So very excited to have Steve on the podcast. Welcome, Steve.
Thank you so much, Igor. I'm delighted to be here.
Fabulous. Well, first of all, I would just love for you to share your background with our audience because it's such a remarkable one.
First of all, I should say that I'm delighted to be here working with PwC. I'm an executive in residence working with the private equity and value creation team, looking at really new investments in healthcare, ways of moving healthcare forward. So a great delight working in, by the way, healthcare and life sciences. As a quick overview, I've been a healthcare and informatics leader in the U.S. and abroad for about 30 years or so now. The settings range from startups to regional specialist care providers and a national health system, the UK, and from practice-based continuous improvement, pay for performance to public policy. I'm somebody who's been in the trenches doing work with clinicians, physicians in particular, all the way up in the UK example with members of parliament to really move forward in terms of this outcomes-oriented thinking that I'm going to describe in our discussion here. The main theme of my work has been around creating clinically meaningful, data-driven solutions, statistically driven, to better integrate and inform the care of persons with complex chronic conditions, more specifically to better individualize care. And typically, I've been working with patients with late-stage chronic kidney disease. There are a number of clinical studies and government reports that outline my work. And in fact, one case study was inducted into the Smithsonian's Museum of American History. I also have a doctorate in bioinformatics. And this is really what helped spark a lifelong interest in how biological complexity impacts the nature of actionable scientific data and ultimately effective decision-making, risk management, and system design. And this has permeated all of the work that I have done.
That's fantastic. And Steve, really looking forward to your insights. And I wasn't kidding when I mentioned earlier that you are outcomes obsessed and that you think very carefully about not just the outcomes themselves, but are we measuring the right things and are we measuring them in the right way? Because that could also introduce a number of errors into our thinking if we're not doing it right. So would love to hear from you about some of the results that you have been able to achieve through your work and what you did differently to drive that kind of performance, those kinds of outcomes.
I should say that this is not my work alone. It takes a team. And one of the people that I worked very closely with was my father, who was a seminal figure in modern nephrology. I think something of the order of 7 papers at least are landmark studies. And a lot of his work over the many years is reflected in my own work. So, Igor, what I thought I would do is focus on a particular case study to illustrate the work. And I'd start with the outcomes, which I think are quite interesting. So typically over the years, we've tended to work with complex chronic patients with late-stage kidney disease. And quite often, and for study purposes, what we've done is we've looked at hemodialysis populations. Now, the reason we've done this is because these are very complex populations with comorbid conditions. Their treatment and care has to be very team-oriented. You have to really be focused on the care of the patient from the hospital to the home. And some of the patients, for example, would undergo nightly hemodialysis while they sleep. And so we had to be able to monitor them in real time. So that was really integrating that whole care team along the continuum of care around these complex patients. And when these patients present, they typically have about 12 conditions. As their situation progresses, the number of conditions increases. And of course, a majority of the patients arrive at dialysis because of the diabetes. As their diabetes progresses, their kidneys begin to fail. So what I thought I would do is start with the outcomes. And here are some data that are published. So everything I talk about is in the scientific literature. For example, in this, we did a 9.5-year study looking at the impact of our approach. And what we found was that hospital admissions were 40% below the U.S. average in this population. Now, keep in mind that the average cost of caring for these patients was roughly about $120,000, $125,000 per patient per year, and about 40% of that is hospitalizations. At the same time, the mortality rate fell by up to 50%. So this was a regional multi-center study to 40% below the U.S. average, so a precipitous drop in mortality rate. The clinical staffing needs was about 25% below the U.S. average. That is, in this approach, we were delivering much better outcomes with far fewer staff. And that's an interesting point. Staff were more efficient and far more effective for particular reasons. We were able to get things such as the cost of medications for treating severe chronic anemia to 35% below the Medicare reimbursement rate, the bundled rate, with better outcomes by international standards. And if you add these numbers up, the cost of care was probably about $25,000 per patient per year, less than what would normally be experienced in this population. So you might ask, well, how do we go about doing this? In our work, we found that we believe, and strongly, that the linchpin of all medical practice, improving outcomes, delivering lower cost, and also, dare I say, around real-world data-based pharmaceutical research, is the patient medical record, but not the medical record in a form that's conventionally thought of. So we designed, and there were prior generations of this and applied with similar effects, we designed a different approach, which basically was a collection, centralized collection of data around everything that happens to the patient. In a sense, if you can imagine it, breaking down all the data elements in healthcare into their most discrete but meaningful gumballs. And therefore, when a patient, and this is across inpatient, outpatient, any combination of disease conditions, includes the dietitian, the social worker, everybody. And so when a patient presents, it's really a matter of reorganizing those gumballs, as it were, to address the very specific needs of that particular encounter for that particular patient, and being able to look at the correlations dynamically at the point of care. But it also means, if you think about it, that a bill, whether it's a Part A or Part B bill, or it means that that too is a reorganization of the gumballs. So what we created was a very novel approach that completely unified the clinical and financial side of healthcare and resulted in much more effective clinical care and much more effective administrative side, the billing side. And we deployed this, for example, the outcomes data that I quoted, we deployed this, for example, in New York, regionally across a very prominent academic institution. And this system existed everywhere. It was on roughly 2,000 workstation. You could access it from anywhere, from the inpatient ward to the home if you were a home-based worker. You could access it, in addition, through the cell network. And in fact, the very first organ procurement for a transplant was procured by a worker, a transplant coordinator, in fact, who was riding home on the Midtown Manhattan bus in 1998. And she was able to open her laptop, have full access to this system, and do what she needed to do to arrange the procurement of the organ, get off the bus, and go home. Pretty extraordinary story, which was conveyed to me by one of the lead physicians with great excitement, mind you, as well. So what is behind this? Well, if we back up and think about what are the cost problems in healthcare, the problem in healthcare in some senses is very simple. We're just not as smart as we think we are. And everybody is different. Each and every one of us is different. Every time we intervene with a patient, that is, in some senses, a natural experiment. We don't really know fully what the outcome will be. So we need to develop feedback mechanisms that allow us to track what works, what doesn't work in each and every patient. So you're really working from the individual patient to the population, not from the population to the individual patient. As people who work with complex patients will remind us, means in healthcare are meaningless. There is no such thing as an average patient. And if we're able to better optimize our understanding of what each and every patient needs, better optimize what treatments work and what don't and whom, this has a precipitous impact on outcomes and costs, and also reduces the requirements for clinical staff, because now we know who the outliers are. We know much better how to treat them, right? And so we can allocate our resources much more effectively as a result.
Steve, that is remarkable in so many ways and so much to learn from this. And you describing this experience or several experiences where you built this nuanced understanding of individual patients and populations and were able to serve them in a way that produced better outcomes, reduction in mortality, reduction in cost, and were able to repeat it, do it with a sizable population. All of those things are very rare and very remarkable, and doing it in a way that doesn't have a huge barrier to entry in terms of technology is also quite rare. And so one of the first questions about any kind of a health effort, innovation model is, how do you bring the clinicians along? How do you bring physicians and other members of the clinical team along and convince them to do things differently, to try something different that usually makes or breaks the experiment?
Yeah, that's a great question. I'll just back up briefly. In my PhD, I looked at a global network of scientists across 35 countries. And the funders of that included the European Union, the National Science Foundation, a number of pharmaceutical companies and others were involved. And I had data use down to keystrokes. And what was very interesting was nobody used it. And so the first thing that everybody did, whether they were a financer, whether they were technical kind of IT people, is they blamed the scientists. And they said, oh, they're computer phobic and this, that. That really was not the problem. The problem was those who conceived and promoted this particular network did not understand how these people create value. They didn't understand the critical issues of biological variability, that people are hunting for needles in haystacks, and if the haystacks aren't comparable, that's a problem, et cetera, et cetera. That is exactly the same issue in healthcare with physicians. To answer your question, the biggest supporters of our approach were physicians, bar none. My work in the UK, elsewhere, it really percolated from the bottom up, promoted by physicians. And the reason for that is this was built by people and conceived by people who were remarkable physicians and who had applied this in daily practice. So as was described to me by a physician in Australia about what they do, this happened to be an emergency room physician who said he apologized because we were supposed to meet on a Saturday and he wasn't there. He said, I apologize. I had this elderly patient who presented and I had to deal with her. And she said, what I do is I try to collect all this different information, the context of care. What is the context? What is her background? What has happened previously? All of these other things. And then I try to interrelate it in my head. I have to create a multi-dimensional spreadsheet to try to figure out for this particular presentation what to happen. Well, with our approach, you don't have to do that in your head. It does it for you in a way that you want. So every single clinician can look at the data differently. And I shouldn't really get too preoccupied with how you look at the data. What I should be preoccupied with are the outcomes. So each and every clinician I have found has a slightly different mental model, the way their brain works, the way they interact with patients. And I'm certainly not in a position to judge which is the right approach and which isn't. In fact, I treasure and value that diversity. But I should hold people to account for the outcomes. And that's what we did. So in terms of the physicians, it made their life easier. And that's the first and foremost consideration. It made their life much more effective. They could actually see that they were having an effect. And at the same time, it made them much more accountable because there was far more transparency in the system. And so there was nothing like kind of peer review and transparency, and also to some extent name and shame, to make sure that people were not practicing unless they were practicing effectively. But at the end of the day, this really transformed decision-making, accountability, and continuous improvement. And in fact, I could build into the system for my patients. I could decide when I see a report or somebody else sees something about my patient, tell me what best practice is for this subpopulation. Tell me whether this individual patient deviates significantly. So this statistically driven feedback, which the clinician could put in, or it could be put in more generally by others. This is a very, very important part of it. Oh, and I should also say, finally, I quoted some rather dramatic figures in terms of outcomes. What's really important to know is nobody was told to practice differently. This was in a prominent academic environment. Every physician was their own silo. This was an organic change that occurred from the bottom up. Indeed, I would argue that had the organization itself been a little bit more focused on enforcing certain approaches and procedures that appeared to work, the outcomes actually would have been a lot better. But there was no top-down focus at all on saying, thou shalt do things this way or that.
Again, remarkable and very unusual. And I want to start pivoting to taking some of the learnings from this and extrapolating them to the broader our health ecosystem. And one of the challenges, at least I believe, why our healthcare marketplace is so dysfunctional is that we can't seem to agree what is actually being bought and sold and what is being reimbursed. And at the root of it is a problem of having a hard time defining what quality means, what quality looks like. And I'm wondering, from your work, what did you learn about quality? How did you learn to think about quality, define quality, and promote quality?
So our work really focuses and has focused on learning from your own practice and your own patient population. So there are lots of guidelines out, but what is not realized is the data behind these guidelines tends to be extraordinarily limited. And it may be that these apply, or maybe they don't apply to my particular patient population. So when you're dealing with a complex, chronically ill person, the most important thing is, are they, the individual, getting better, or are they getting worse? And then the other thing we find is, quite often with guidelines, we have a threshold, oh, your patient should get to such and such a level. In fact, we don't really know. What we found was these patients get a lot better if you take this heuristic, iterative approach. So the baseline is the patient themselves. Then you can compare the patient to a subpopulation of similar patients. And in fact, the individual clinician can do that themselves. They can say, oh, here's a patient with a particular problem. I'm not quite sure what to do. Let's look at a subpopulation. They can do that very quickly at the point of care. Is there a similar problem? Do we learn from that? So quality really is about, first and foremost, outcomes. For us, it was not about whether you adhere to a particular guideline. It's about mortality, morbidity, hospitalizations, and then all of the detail that's associated with that.
That's very impressive and not for the faint of heart. Most organizations start with process metrics and often never quite move to the outcomes metrics because it's a much higher bar to meet and a much greater risk potentially to be accountable for achieving those outcomes. And as you already mentioned, accountability, there are different business models around this, different ways to get paid for outcomes and for results, and different pressures to make it financially sustainable, to deliver that care that's unique to the needs of each patient. And so I'm curious how you see these clinical models that are able to deliver outcomes. What is the business model around it, and how do you overcome some of the sustainability challenges and affordability challenges through these clinical models?
My work is always focused on the clinical and the financial, what I call clinical risk management and financial risk management. And of course, if you align the clinical risk, if you have a system such as capitation where you're aligning the clinical and financial risk, we have synergies there that are really very, very important. So for example, in that case, we move from a very different notion of marginal cost in a transaction as we encounter a healthcare provider. Today, or in the most rudimentary system under pay for performance, really what we focus is on the marginal cost of each and every healthcare transaction. We want it to be as low cost as possible. However, if you move to capitation, we have a big shift because what's most important is the marginal effectiveness of that encounter. To what extent does my encounter with that physician reduce or eliminate future encounters that are required? And that's very, very important. So that's bringing together this clinical and financial risk because healthcare is really a risk management business. It's about having a patient who presents here and now. I can't do anything about the past. The patient is here. What I'm trying to influence is the future progression of disease, the onset, whatever it's going to be. And if you think about that, what we're really talking about is utilization of resources. That's a business problem. So I'm going to go back and I'll just give you two quick case studies about how this approach actually helps you to manage business problems, very practical ones. One, numbers of years ago, using the same approach for the prior version of the system, a fundamental problem was how do we expand our, in this case, it was a dialysis facility. We've got many more patients. Do we build a new facility? Do we add more to the existing facility? How are we going to finance that? So what the clinician said is, wait a second, let's go back and rethink what we're doing in terms of our clinical processes. Can we dialyze patients differently so that we can take the exact same capital that we have here, the building, the infrastructure, and everything else, and have more throughput without adversely impacting incomes? So they took their clinical system. They were able to set up an in-center controlled study using their patient because they had all of this computerized data in the form that I've described. And they actually pioneered, this was some time ago, the reuse of dialyzers. Now, why was that important? Because they identified a new high flux dialyzer that would allow them to reduce the amount of time on dialysis. But that dialyzer cost $45 a throw, whereas the conventional dialyzer cost $12. The financial people said that would never fly. So looking back at some clinical literature from the 60s, they said, maybe we could reuse these. So they set up that study I mentioned. They pioneered reuse, and they demonstrate that actually had better outcomes than previously. So they delivered better outcomes. Now, how much reuse did they do? They reused up to 35 times. So that $45 dialyzer now was used 35 times for some patients. But they also found that each and every patient responded to that reuse differently. So they were able to identify who and how and this, that, and the other thing and tailor reuse to individual patients. So that was some time ago. Now let's take a look at a second example, which was a few years ago, which was dealing with the Medicare bundling of erythropoietin stimulating agents, EPO and the like drugs, and reimbursement. Those were bundled, and therefore the provider now suddenly had to bear the cost rather than the payer of those drugs. So what we did is we looked at this condition for which they use severe chronic anemia, and we were able to take this information system and do a 9.5-year retrospective survival analysis using Cox hazard techniques, and determined that, in fact, the magic bullet wasn't the EPO, and this is all published. It was iron. This was contrary to international guidelines and accepted ways of doing things. And in fact, that if you didn't replete the patient fully with iron, the ESAs did little, if any, good. And if you did replete them, you needed far less ESAs. Moreover, they found that the timing, the number of times you changed the dose over the course of a year of these ESAs, and the amount of the dosing time changes was critically important. They then used this to create a 44 variable model which they reviewed each and every patient's care every month very quickly using this model. The consequence of that was their costs took them about 6 months to get the cost down. We're 35% below the Medicare reimbursement rate with some of the best outcomes in the world. If you look across 7, 8, 9 countries, I can't remember exactly which countries. Now, the punchline is this. That study probably took them about 4 months and $30,000. The $30,000 was used to hire an academic biostatistics team from a different university to do the analysis. That's very, very inexpensive. But they were able to do it because the design of our system was collecting in daily practice, starting several years ago, data which were scientifically valid, analyzable, and could be applied to any kind of retrospective study thought about in the future.
Steve, these are fantastic examples, and I love the specificity of it. And again, I'm thinking about extrapolating this to the broader health ecosystem. And you've mentioned several challenges and several kind of keys to this, which is the ability to customize the care to the patients and as well as to the preferences of the physicians, to forecast the disease progression and resource utilization, to manipulate large data sets with lots of variables and maybe find some unexpected relationships between them. All of those tasks, all of those challenges seem to lend themselves to the use of some of our most recent tools, including artificial intelligence. So I'm curious to see how you're thinking about, does artificial intelligence change the equation? Does it make things easier? Your thoughts on the role of AI in contributing to this?
When we first designed this approach, we had neural networks in mind because everything in healthcare is about patterns and interrelationships. Particularly any single data point that really has limited value. Its value rises based on my ability to interrelate it with other data points and other data points across domains. So artificial intelligence, and in particular machine learning at this point, is extraordinarily useful. But not as a way to replace a clinician, but rather a tool that can be used to identify relationships and to pick up subtleties in the data that perhaps nobody had ever thought about, but actually are significant. And one really good example of that was a study done a couple of years ago that applied machine learning to large data sets and looked at the impact of ambient temperature on lab results. And what they found is that in a large proportion of those lab results, ambient temperature was statistically significant. That is, the ambient temperature was associated with the result, that if the ambient temperature changed, the result changed. However, that's not the punchline. The punchline is not about ambient temperature in the lab. The punchline is that it was the ambient temperature on the day or up to 3 or 4 days before the bloods were drawn that affected the results. Now, the differences were significant but fairly small, but they were large enough that they found that there was a 10% change in the prescribing of statins to patients based on ambient temperature. And so this is new. This is something that's being explored further, but it just tells you something about the complexities of medicine. And it also tells you about the power of machine learning and AI potentially, that we can find these patterns and begin to address them. The other thing I should say is AI and all of these are really tools. One of the things they really are helpful with, and this lab study that I mentioned is illustrative of that, is they really help us to identify and potentially test new hypotheses, to think differently about problems.
Steve, again, so much rich information here, and these are fantastic examples of some of these new tools potentially helping us uncover some unknown unknowns. And the big question for me as we bring this great conversation to a close is, how do we as a system start transitioning towards this different way of taking care of patients and population that you're describing, a way that's more patient-centric and patient-specific, but also accommodating of different physician preferences, the way that's more long-termist in its outlook, the way that's more financially sustainable and more thoughtful. How do we get from where we are today to the kind of performance and the kind of results that you're describing?
That's a terrific question, Igor. It's a tough question. Throughout my career, I've always focused, I'm not a great believer in grandiose projects. When I got involved in the UK, I said to them, let's not be grandiose about this. Let's carve out areas where we can deliver benefit, significant clinical and financial benefit, and work from there out. Get the models up and running. If we look at the U.S., the exciting potential to me seems to be really in what I call the carve-out space, which is not new. We were doing that in the 1990s. I remember being involved with renal carve-outs, for example. But the key is that are these efforts capitated or are they moving to capitation? Do they have a high degree of control over delivering the results? That is, I can have a really wonderful information system, you put it in there, but if you have no control over how it's used, who uses it, and all of these other factors, it's very difficult to have control of the results. So those entities that are out there, there are interesting initiatives that have been started in primary care, focusing, for example, on Medicare populations and others. There are some interesting initiatives that focus on populations with complex chronic conditions, notably chronic kidney disease is one. But it is tough because we live in a system where we don't have a system, really. We don't have an integration. And, the person is an integrated being, yet we fragment their care across a whole range of different providers. And in order to really deliver much better care at much lower cost, we have to really start focusing on people as that integrated being. And the challenge is how to do that.
Steve, thank you. That's such a clear and such a powerful message, and yet it is still somehow non-obvious and seems to elude us. But today's conversation was very illuminating in terms of what good looks like, what are the watch-outs along the way, what are all the things that we have to get right, and really appreciate you joining and sharing your experiences, and looking forward to all the work you're doing as our executive in residence.
Well, thank you very much. A delight to be here.
For more on these topics and other health industry insights driven by policy, innovation, and care delivery changes, please be sure to subscribe to our podcast so that you can get all of our great future episodes and listen to all of our great past episodes. Until next time, this has been Next in Health.
This podcast is brought to you by PwC, all rights reserved. PwC refers to the U.S. member firm or one of its subsidiaries or affiliates, and may sometimes refer to the PwC network. Each member firm is a separate legal entity. Please see www.pwc.com/structure for further details. This podcast is for general information purposes only and should not be used as a substitute for consultation with professional advisors.